Okay, here we go. Thoughts for the day. This is not a field for everyone. If you pass this class, you become part of this EMS community and team. You become part of a unique group of people with critical thinking skills, the ability to work and act in extreme environments under extreme pressure. And most people have no concept of. They think they have because they've watched a lot of TV shows. But until they're out there trying to hold an airway open and stop bleeding as an 18-wheeler going by at 70 miles an hour blowing snow all over them, you don't have any concept, trust me. Never sell yourself short. If you're here, you're doing this, and you're making it work, you've made a huge accomplishment. Never sell yourself short. When you're done with this, you're going to think it's easy. You're not going to understand why other people can't do it, but that's only because you've done it 1,000 times in this classroom, and it's going to be burned into your brain. So when your pager goes off 3 a.m, you're going to go. Things that be fine. You will, trust me. All right, we're going to go over the anatomy of the upper and lower airway, which you've already been over at least 3 times before. We're going to go over it again. We're going to go over the physiology of the respiratory system, understand the types of respiratory emergencies, their treatments, and go over the 5 types of breath sounds. We're going to know the generic name of medications, forms, dose, administration, action, and contradiction of medications for respiratory patients. We're going to go over the pandemics and especially influenza A, which is an enormous killer and is right now as we speak. Understand the differences between pediatric and geriatric emergencies versus healthy adults. Any questions? You guys have seen this picture lots. You should know it. Any questions? All righty. So, how does breathing work? So we contract our diaphragm and intercostal muscles. It expands our chest, creates less than atmospheric pressure. Atmospheric air runs in. Oxygen exchanges for carbon dioxide at the alveoli level. Then we relax our diaphragm and intercostal muscles. It creates greater than atmospheric pressure. The carbon dioxide rich air runs out. Then we start the process over again. Any questions? All right, normal characteristics of breathing. Everybody in here, including myself for once, are breathing adequately. You should have good equal chest sounds. You should know what good equal chest sounds sound like by now. Symmetrical rise and fall of the chest. Normal warm dry skin. Any questions? Inadequate breathing, that's when, for whatever reason, your pulmonary system becomes obstructed, whether it's a blood clot in the circulatory system, damaged alveoli, constriction of the bronchuses, the bronchioles, or the lungs fill up with fluid. Any questions on the characteristics of inadequate breathing? No questions. Moving forward. How are you going to know when someone's doing that? Well, they're going to be breathing too slow or too fast, with not enough tidal volume to exchange gas. You're going to notice that from chest not being fully expanded, not hearing adequate breath sounds, muscle retractions in the accessory muscle areas of the neck and the clavicles. Any questions? Slow and shallow and fast and shallow on the test will always be inadequate breathing. You need to know what dyspnea is. It's a vocabulary word you must know. It means shortness of breath and difficulty breathing. People that are in impending respiratory failure or towards the end of the respiratory failure are probably not going to be able to speak to tell you that they can't breathe, but you're going to have to know by the other signs and symptoms. Cyanosis, low tidal volume, too fast, too slow. Any questions? Decreasing oxygen saturation. So this is a person, this is what COPD looks like. This person's like this, pursed lip breathing, accessory muscle usage, 24 hours a day, 7 days a week. I don't recommend it. Probably something you want to avoid. It's chronic obstructive pulmonary disease. So what can cause dyspnea? The most common cause of dyspnea is upper respiratory infection or a lower respiratory infection. Abbreviated URI, ULI. And that's a big catch-all for all viral and bacterial respiratory diseases. Acute pulmonary edema, which means acute means came on suddenly, as opposed to chronic, which means long-term. So acute pulmonary edema is a sudden onset of fluid in the lungs. Edema is fluid buildup. Pulmonary is lungs. Acute pulmonary edema means sudden fluid buildup in the lungs. COPD is chronic obstructive pulmonary disease. That's a catch-all for diseases that never go away. Once you have them for life. Most common one is emphysema, followed by chronic bronchitis, followed by chronic asthmaticus, followed by black lung, and then a whole bunch of more or less common ones. Acute asthma, anaphylaxis, which is a full systemic, full body allergic reaction. A pneumothorax, which is a collapsed lung. You guys know about those. Pleural effusion, which we're going to go over. That's when fluid collects up from a disease process, kind of like a hemothorax, but it's body fluid instead of blood. Very not good at all. Prolonged seizures. Of course, any type of airway obstruction. Pulmonary embolism, which is a blood clot going down your pulmonary artery and obstructing blood flow to the lungs. You can't exchange gas. Environmental exposure to smoke, etc. Carbon monoxide poisoning. So carbon monoxide, your hemoglobin, which is what carries your oxygen, prefers carbon monoxide over regular oxygen 200 times to 1. So it's extremely poisonous and will kill you quickly. And of course, infectious disease brings it back up to the top. Any questions about things that can cause shortness of breath and difficulty breathing, also known as dyspnea? All righty. URI and LRI. So types of airway obstructions, epiglottitis, that's a gnarly one. Much more prevalent in children than adults, but adults can't get it. So the epiglottis is a flap of skin that protects, or the flap of tissue that protects your airway from food and drink going down into your trachea, so it diverts it down your esophagus. When it comes infected from either viral or bacterial infection, it swells. And if it swells too big, it'll shut your airway off completely. Nobody wants that. We'll go over the signs and symptoms of it. Oh, must be Mount Shasta. Croup. Croup is a disease that's pretty much between the ages of 2 and 5 years old. An upper respiratory infection causes bronchoconstriction. Kids will have a seal-type bark when they cough. So regular cough, it'll sound like a seal. Only way you can truly diagnose it in the field is to take a beach ball and see if they can spit it on their nose. Respiratory syncytial virus, also known as RSV, also very deadly for children. Makes adults very, very sick too. It's similar to the flu, but it's not the flu. The similar signs, symptoms, and results. So for adults, it makes us very sick. RSV does. We have runny nose, we have mucus in our airways, we get a horrific cough, we get infections from the mucus. But what we do is adults, we've got calcified rib cage and strong intercostal muscles and diaphragms, we can get barrel pressure, we can hack up, and we can spit out all the big green and yellow loogies from RSV and from pneumonia. Kids, you remember, have little tiny soft airways. They only have their diaphragm, and their rib cages aren't even calcified, so they can't build those airway pressures to hack out those mucus plugs that are causing them to block their airways. So for kids, RSV can be fatal. Very, very dangerous. Same with pertussis, also known as the whooping cough. SARS, we don't see a lot of anymore. That was a real big scare thing before COVID. I don't even remember the name of it anymore. I can't remember the name of it. Anyway, it came from Asia, just like COVID. It was a very big, very similar to pneumonia. Influenza A, which is the #1 killer, still is the #1 killer. Got overthrown in 2000 by COVID because everybody was taking so many precautions. Basically, no one got the flu. But we were taking flu precautions because no one knew how to handle COVID. And that didn't slow COVID down really. But anyway, now the flu's back and stronger than ever. Yes.
Is it just type A or B as well?
Oh, B2. But
Okay.
A is the most prevalent.
Okay.
B you don't see as much. Then you got H1N1, which is swine, which comes around every 4 or 5 years, which is also very deadly. Then you got meningococcal meningitis and COVID, COVID's been around forever. It's a common cold. Any questions? All right, epiglottitis. So this is a highly fatal disease if not treated, especially in kids. Very, very fatal. So their epiglottis will swell so large that they can't swallow. So their saliva buildup will build up their mouth and they'll start drooling. So you'll naturally start tripoding, trying to get as much expansion of your chest as you can. So try to use gravity. So you go do what's called tripoding. Look like an offensive lineman, ready to go for the hike. Drooling, and then you hear stridor. Stridor is a high-pitched whistle on inhalation, not exhalation. On exhalation, a high-pitched whistle is called wheeze. When they're inhaling, that's correct. Do not put airways in these people, either nasopharyngeal or oropharyngeal. If you touch the epiglottis, you'll aggravate it and it will swell more. Some of these people only have a 2 to 5% of their airway even available. This is a true emergency. Any questions?
Can you say what stridor is one more time?
It is a high-pitched whistling on inspiration. Hurts my throat. Questions on epiglottitis? It does happen to adults, but it's way more prevalent in children. Ah, here's an adult with epiglottitis. That's a video of it. And music. You can always have happy music right before we die. That's a huge, see how much, he doesn't have much airway there, does he? How much air do you think that guy was getting? Almost none. Yeah, kids are way more prone to getting it.
What do you do to help their way out?
So no, I mean, nebulized epinephrine, get an advanced life support, start moving towards the hospital. If you can get advanced life support on the way, nebulized epinephrine, because epinephrine is a vasoconstrictor, so it'll shrink the blood vessels in the infected epiglottis and shrink it a little bit, buy them a little time. Then we get to the hospital, hopefully they're gonna paralyze them and then intubate them. Get a tube in there so they can swell around the tube until it can, then at least you've secured the airway. I don't know, days. It depends if it's viral or bacterial. Bacterial, you get IV antibiotics pretty quick. Viral may take 2 to 6 days to pass. All right, here's a little type with croup. That's what Strider sounds like. When he exhales, that's a wheeze. And if you look really closely at the sternum, you can see it's actually bending in because his rib cage is so soft. That's called sternal retractions. That wasn't a very good croup video. He didn't bark. So croup, 3 to 5 years old, or 6 months to 3 to 5 years old. Signs and symptoms is tripoding, the seal-like bark, and dyspnea. So for these ones, like if you're waiting for an ambulance or you're gonna, you can like turn a shower on, or any humidified air or steam will help. Any questions?
Access to like sterile water or saline, did you potentially take like tap water and nebulize that for the kiddos?
Good. Tap water is not sterile though.
I mean, yeah.
But I mean,
I mean,
I recommend just turning the shower off, it's just tap water. Oh, hot to steam up a bathroom and get them in there and have them inhale the steam. The best thing to do is start transporting towards the hospital. If you don't have that ability, get a hot shower going as hot as you can, and just fill the room full of steam. Any questions? Maybe this guy's got a better bark for you. There we go. Sounds to me more like a raptor at Jurassic Park, but. Sternal retraction, see the sternum? Diaphragm just working away.
Good, right?
It's good that it's working away, but he's gonna get tired if somebody they don't get this under control. I guarantee you these parents or nurses or paramedics, because nobody else would film their kid like this, they give them to a freaking doctor. It's like, oh, we got this.
I'm glad that they have this. They just have to-
Yeah. Good Strider too. So he's only gonna have enough glucose. He can't keep up that rate. Literally for more than a day or two. He's gonna run out of glucose, he's gonna run out of energy, they don't go into respiratory failure. You don't want that.
That just looks like some of the issue.
What they do is start becoming altered, their sats drop, they'll start getting bradycardic, smooth muscles, which is relax. Yeah, they die quickly. What's that? Yeah. Antibiotics. How about CPAP? That'd be a good idea. What?
They're already trying to.
No, right. Their airways aren't strong enough. They're under 8 years old. Can't handle the higher airway pressures.
That, they have to be able to be alert.
Yes.
So, I think the question for that would be like, a lot of study or.
What causes pneumothorax? All right, RSV. Again, and under 2 years old, it can be fatal. Difficult to tell you the common cold because it basically is the common cold. Not quite though, it's got a little different DNA. But it's very similar. Highly contagious. Any questions?
Same symptoms of the common cold.
Which are the same symptoms as COVID, which because the common cold is COVID. It's just highly contagious. Problem now is common cold's also highly contagious. Jumped 200 times in contagiousness in 1 year. Any questions? Whoopee God. It's making a big comeback because there's a lot of kids that aren't vaccinated. Almost had it wiped out. It was only prevalent in third world countries. Now it's becoming big in America again. Same with measles. Making a comeback. Any questions? At the top, it sounds like a whoop. So none of these viruses kill you, but they lead to pneumonia. Then pneumonia leads to sepsis, which then leads to septic shock, which then kills you. Any questions?
I got one.
Yeah,
Was it just an infection of the alveoli? Like, what is it infected in?
it's an infection of your entire respiratory system,
Oh, okay.
which then leads to phlegm and goop and pus getting up, covering your alveoli, and then not being able to exchange gas, and then that was septic shock.
Gotcha.
It's a multi-systems going down the drain. Get you from multiple aspects. SARS. Why can I not remember the name of SARS? Acute respiratory syndrome. Sudden acute respiratory system? No.
Or severe?
Severe acute respiratory syndrome. Yes, thank you. This is what spread before COVID-19. Any questions? Matter of fact, they use the SARS-2 test, is what the COVID-19 test is. Very, very similar. They just perfected it more with COVID-19. Any questions? And here's the biggie, Captain Trips, influenza A. Does the same thing as SARS and COVID and RSV. Is gives you an upper respiratory infection, which leads to pneumonia, which leads to sepsis, which leads to septic shock, which leads to death. So if you're very young or very old or immunocompromised, very bad. If you're a young, healthy adult and you get it taken care of, probably you'll survive it. Might miss a week of work or so, but you'll get through it. But if you're in one of those other categories, it'll be life threatening. Any questions? Meningitis can be viral or bacterial, and it can also kill you. Same thing. Lead to pneumonia, which leads to sepsis, leads to septic shock, which leads to death. Any questions? If you're young and have a strong immune system, you'll probably kill it. If you're very young or very old or immunocompromised, you're in big trouble. Oh, COPD. There are millions of people with COPD, and it's a big problem. Emphysema is the most common, followed by chronic bronchitis. I had it backwards. Black lung is more common than chronic asthmaticus. We don't see a lot of black lung up here because black lung is prominent in coal mining communities. People that spend hours and hours and hours a day in coal mines get black lung. Chronic means it's never going to get better. It's always going to be there. And if something else doesn't kill you first, it will eventually kill you. That said, the good news is there's a lot of new steroids out there that can really prolong your misery. Any questions? Now here's something we hope you'll really like.
Understanding chronic obstructive pulmonary disease, COPD. Chronic obstructive pulmonary disease, or COPD, is a lung disease that makes it difficult to breathe. COPD is a long-term disease that often gets worse over time and is characterized by inflammation and severe limitation of airflow in and out of the lungs. COPD is an umbrella term used to describe a group of breathing conditions, the most common being chronic bronchitis and emphysema. Many people living with COPD may have both emphysema and chronic bronchitis. A few people have both asthma and COPD. Cigarette smoking is the leading cause of COPD. Long-term exposure to secondhand smoke or irritants such as air pollution, dust, or workplace fumes, and biomass exposure, such as wood smoke, can also contribute to COPD. An uncommon genetic disorder called alpha-1 antitrypsin deficiency is sometimes associated with COPD. Although respiratory infections such as influenza and pneumonia do not cause COPD, they can make people with COPD very sick. Therefore, it is very important to keep these vaccinations up to date. At first, COPD may cause no symptoms or only mild symptoms. As the disease progresses, common symptoms include shortness of breath, wheezing, and chest tightness, especially with exercise, and an ongoing cough, often with a lot of mucus. As COPD symptoms worsen, breathing requires much more energy, and it can get harder to exercise or do routine activities like getting dressed or climbing stairs. This may lead to fatigue, weight loss, and muscle loss. People with COPD can experience a variety of symptoms. Different stages of COPD range from mild to moderate to severe. In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs, called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped, and there are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult. COPD is the third leading cause of death in the United States and affects more than 13.5 million Americans. It is predominantly diagnosed in middle-aged individuals older than 40 years and is present in both women and men. Although COPD is more common in men, more women die from this disease each year than men. The rate of COPD continues to increase worldwide due to smoking and worsening air pollution. While there is no cure for COPD, you can take steps to feel better, stay more active, and slow disease progression. COPD can be managed by consulting early with your healthcare provider, seeking diagnosis and intervention therapies, and adopting lifestyle changes that include quitting smoking, pulmonary rehabilitation, healthy eating and exercise, and maintaining a positive outlook.
All righty, asthma. So asthma is a spasm of the upper airways that lets you take air in, but you can't get air out, traps it. And then to make matters worse, it also releases mucus, which then clogs up the already constricted airways. It's episodic, meaning that it comes in episodes. You can live a perfectly normal life until a trigger triggers an episode. And then it can be life-ending. Signs and symptoms are tripoding, just like epiglottitis, but wheezing, which is a exhaled whistle. Usually you can hear it with the stethoscope. If you can hear it without a stethoscope, that's called audible wheezing. And of course, difficulty breathing. These people need oxygen and epinephrine quickly. You guys will be able to give them intramuscular epinephrine. Use it in caution for people over 40 and people without cardiac history. Any questions?
Asthma is a chronic long-term condition that can be managed but not cured. Asthma affects the airways of your lungs. It causes the airways to narrow and swell, resulting in wheezing and difficulty breathing. During breathing or respiration, air goes in through our nose or mouth to the upper airways, at which point it reaches the windpipe, which branches into two large bronchi to reach the lungs. The lungs are protected by the rib cage, which also contains the muscles that control your breathing. In asthma, the airways are oversensitive and easily irritated by certain triggers, called asthmatic triggers. Most people with asthma are described as atopic, meaning they have an allergic type reaction to external triggers, such as house dust mites, pollen, cigarette smoke, animal fur, and chest infections. However, for some people, the onset of asthma is unpredictable and may be caused by anxiety, stress, or even laughter. An asthmatic trigger causes the airway walls to swell and the muscles around the airways to contract. The airways narrow, and breathing through them produces a whistling sound called wheezing. Mucus is produced from the lining of the airways, which clogs up the narrowed airways further and causes coughing. This makes normal breathing more difficult, producing symptoms of asthma that can be mild, moderate, or severe and life-threatening, where hospital treatment is needed. The narrowing of the airways is reversible if the trigger is removed, or if the inflammation is treated medically. Therefore, preventative treatment is used and can be managed by the patient themselves. An acute asthma attack requires medical intervention, but the type of intervention depends on the severity of the attack. For more information, visit
Any questions about asthma? All right, so this one, there will be test questions on also. There's test questions on all these. This one's a little bit different. This one people get confused with cardiac because it's a crossover cardiac and respiratory condition. It's called congestive heart failure. So when the left ventricle becomes too weak to pump adequate blood flow, your body compensates. And it causes vasoconstriction, tachycardia, and it retains sodium in the kidneys. So the problem is the right side of the heart, the right ventricle is still pumping a good amount of blood to the lungs. So the left ventricle can't then pump the blood back out to the body. So where's that fluid going to back up to? The lungs. Going to back up out the pulmonary left atrium, down the pulmonary vein and into the lungs. This is why your cardiac anatomy is so important in understanding the blood pathways. And they're going to start getting really short of breath, hypertensive, tachycardic. They're going to have rails. You're going to hear the gurgling when you listen to the stethoscope. You're going to hear the rails, the bubbling inside the lungs. And that's eventually going to lead the right ventricle to start failing because of the compromise. And then when it fails, then the blood's going to start backing up to your vena cavas. It's going to go into your jugular veins. Are going to start getting plump, and your feet are going to start swelling from the inferior vena cavas. The blood's just backing up. Good news is this is a terrifying condition. These people are tachypneic. They have big time labored deep respirations. They can't breathe. They're tripoding. Their blood pressure's through the roof. They're tachycardic. Their jugular veins are protruding out. They can only speak one or two words without having to take a breath. And they're literally drowning in their own fluids. The good news is, back in the old days, I was an EMT, we had to try to bag these people with positive pressure, holding a mask over their face and try to squeeze in air until a paramedic could get there and nasally intubate them. You guys now have a tool called CPAP. This is the perfect tool for CPAP. CPAP, you put them on, it increases the air pressure inside their lungs, which then puts pressure against their great veins, great vessels inside there, the vena cavas and the aorta and the pulmonary artery and pulmonary vein, and it lowers the blood pressure, increases the oxygenation, and it's like turning a light switch on. They go from not being able to talk and breathe to, wow, I feel a million times better. And the CPAP literally works that fast.
Wouldn't a CPAP be contraindicated because it would ruin their hypoxic drive?
Only if they're COPD, this is CHF.
Oh, okay, so then if they have both, then nobody would see it.
Well, if they have COPD and they're in CHF, are they going to die if we don't put them on CPAP? Probably. So they may have to have them on a ventilator later, but at least for now, never withhold oxygen. Then it's going to take 8 to 10 hours for that to happen, to wipe out their hypoxic drive. You don't have enough oxygen so you'll be okay.
Okay.
Any questions? Now here's something we hope you'll really like.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster, and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Any questions? Yes.
So, like actual like effects of, well, I know what the effects are, but like what causes VHF again?
Left ventricle weakened, usually from a heart attack.
Okay.
Cells have died, and the left ventricle just can't pump the blood out to all the cells in the body.
And then that just causes other systems in the body to increase.
And they got to compensate, and it goes circling the drain, the failure.
Makes things worse. Okay.
Yep. So you'll see test questions. They'll give you these signs and symptoms. They'll ask you what's wrong or what to do. Those are all the signs and symptoms of congestive heart failure: dyspnea, high blood pressure, tachycardia, rails, JVD, pedal edema, means swelling in the feet. Any questions? All right, spontaneous pneumos. So spontaneous pneumos are pretty prejudiced and racist. They occur mostly in tall, thin, fair-skinned males with sunken chests. Does everybody know Talon? Talon is the walking poster child for spontaneous pneumothorax. It's a paramedic from a chest ambulance. So these happen spontaneously, meaning not non-traumatic. They and also if they smoke, it also causes smoking is not a risk factor. But these people just have a spontaneous failure on their lung wall that leaks air into the pleural space and causes their lung to collapse. It can happen to anyone,
Sausage egg biscuit is perfect.
especially if they eat sausage egg biscuits. It can happen to anyone, but it's mostly prevalent in those type of people, that DNA. Any questions? That was in every language. All right, next one brings us to pleural effusions. Pleural effusions never have happy outcomes. This is when you start collecting fluid instead of air in the same spot. Bad news is it's usually from some type of a severe infection or cancer. And especially from mesothelioma. What they can do is they can, you can get them in the hospital, they can tap it. They can put a needle in the pleural side, they can drain the fluid off, but it's gonna come back in a day or two.
You think never get rid of it?
If not, if it's cancer. I mean, you never know. I mean, there's new treatments every day and immunotherapies, but it's bad. I've never seen a happy outcome from pleural effusions. Unless it's just an infection that gets cleared up, but that's pretty rare. Usually, almost always when there's a pleural effusion, there's an underlying cancer.
Hello, this is Dr. Carlo Poget, emergency physician and founder of EVExitvideo.com. This video is about pleural effusion. A pleural effusion is a buildup of fluid between the layers of tissue that line the lungs and the chest cavity. As seen in this picture is the blue area on the bottom left of the picture. Your body produces pleural fluid in small amounts to lubricate the surface of the pleura, the thin tissue that lines the chest cavity and surrounds the lungs. Pleural effusion is an abnormal, excessive collection of this fluid. There are two types of effusions. Transudative pleural effusions are caused by fluid leaking into the pleural space. This is caused by increased pressure in or low protein content in low blood vessels. Congestive heart failure is a common cause. Exudative effusions are caused by blood vessels like inflammation, lung injury, and drug reactions. Symptoms of an effusion include chest pain, cough, fever, hiccups, rapid breathing, and shortness of breath. However, sometimes there are no symptoms. Signs and tests. During a physical examination, the doctor will listen to the sound of your breathing with a stethoscope and may tap on your chest to listen for dullness. The following test may help confirm a diagnosis. A CT scan of the chest will show a loculated pleural effusion you can see on the left side of the chest. A plain chest x-ray. In this picture, you can see the heart is blunted by this white density on the left side of the chest, the right side of the picture. This is pleural fluid. Pleural fluid analysis. Examining the fluid under a microscope to look for bacteria, amount of protein, and presence of cancer cells. A thoracentesis is the procedure by which we put a needle into this cavity to drain the fluid. Treatment of a pleural effusion aims to remove the fluid, prevent the fluid from reaccumulating, and treating the cause of the fluid buildup. A therapeutic thoracentesis may be done if the fluid collection is large and causing chest pressure, shortness of breath, or other breathing problems such as low oxygenation. Removing the fluid allows the lung to expand, making it easier to breathe. Treating the cause of the effusion then becomes the goal. For example, pleural effusions caused by congestive heart failure are treated with diuretics, water, and other medications that treat heart failure. Pleural effusions caused by infection are treated with antibiotics. In people with cancer or infections, the infusion is often treated by using a chest tube for several days to drain the fluid. Complications of pleural effusion include a lung that is surrounded by excess fluid for a long time may be damaged or injured. Pleural fluid that becomes infected may turn into an abscess, also called an empyema, which will need to be drained with a chest tube. And the pneumothorax, which is air in the chest cavity, can be a complication of the procedure done to drain it. If you were diagnosed with a pleural effusion, but the underlying cause has not been identified, then it is most important to follow up so more tests or procedures be done. If you have fever, chills, increasing shortness of breath, chest pain, or feeling faint, if you have any new or any progression of the symptoms seen the first time.
Any questions? All right, status epilepticus. That's when you have a seizure that doesn't stop. So when you have a seizure, you lose control of all your bodily functions. Your muscles completely get rigid and rhythmic jerking, and you can't inhale and exhale because that's how you breathe, is through contraction and relaxation of your intercostal and your diaphragm. And when they're seizing, you're not breathing. So you start turning purple and it's not good. And it causes hypoxia. Only thing you can do as EMTs is get them moving towards someone that's got a medication that can stop the seizure. Any questions? This brings us to pulmonary embolisms. This is a very unfortunate and very common occurrence in the United States. So pulmonary embolism is when you have a blood clot, usually starting in the leg, that breaks free, travels up your inferior vena cava, goes into your right atrium, crosses through your tricuspid valve in your right ventricle, down your pulmonary artery, until it lodges and blocks blood flow to a smaller artery inside your lungs. One of them, unless it's the big one, probably is not going to kill you, but usually they don't come alone. They come in multiples. And kind of like an asteroid storm. And they block all the blood flow to your lungs and you die. This can happen to anyone at any age. There are risk factors. One risk factor is not bad, but for each additional risk factor, it doubles and triples the chance of you getting a pulmonary embolism. I have seen the people die from these in minutes. I've seen people die from these in hours. And it's pretty helpless because there's not a lot you can do. Outside of getting women to interventional radiology and hopefully they can do a thrombectomy. But that's a pretty tall order. But here's something we hope you'll really like.
If you are immobile for an extended period of time because of surgery,
Must be in
pregnancy,
weed.
illness, or travel, you may be at risk for deep vein thrombosis, or DVT, a condition where a blood clot forms in a deep vein in the body, typically the leg. Unlike arteries, which rely on the heart to force blood through them, veins transport blood with the help of muscle contractions while you move and walk. Veins also have valves that keep blood from flowing backward and pooling in your arms and legs. When you are immobile for an extended period, your venous circulation slows down. As a result, clotting factors in the blood may cause the slow-moving blood to clump together, forming a blood clot or thrombus. This condition is called deep vein thrombosis, or DVT. Common symptoms of DVT include swelling of the leg or a vein in the leg, pain or tenderness in the area, increased warmth in the skin, and red or discolored skin. In some DVT cases, a blood clot may detach from a deep vein and join the bloodstream. The clot travels from the deep veins of the leg, through the veins of the abdomen, into the heart, and finally lodges in the pulmonary artery or its branches, blocking blood flow to the lungs. This condition, called pulmonary embolism, is very serious and may permanently damage a portion of the lung. If a clot is large, or if there are many clots, pulmonary embolism may also cause death. If you experience symptoms of PE, please tell your doctor or nurse immediately. These symptoms may include shortness of breath, a sudden sharp pain in the chest, a feeling of lightheadedness or dizziness, rapid or irregular heartbeat, or coughing that produces blood.
Also as
To help
hematopsis.
prevent deep vein thrombosis and pulmonary embolism, your doctor may require you to do the following. Walk around periodically to keep the blood from pooling in your legs. Wear compression stockings, and take anti-clotting medication.
Any questions? So, risk factors, any one of these risk factors can cause it. But the more of these risk factors you have together at the same time, the more likely it is to happen. So smoking or any nicotine products, vape, chewing tobacco, snuff, patches, gum, nicotine is a massive vasoconstrictor, which means it constricts your blood vessels. So then you have increased clotting. Post-surgery, people that get surgery are immobile for a while. So that's why they end up with any long hospital stay or sedentary lifestyle. People that don't move grow clots inside their veins. That's why a lot of times you go visit someone that's in an ICU or a long hospital stay, they'll put stockings on them with an air compressor that compresses up and it squeezes their legs and lets go and squeezes their leg and lets go. What they're doing, that's an anti-clotting mechanism. So they don't get out of bed when they finally get to go home and then throw a clot and have PE and die right there in the hallway. Because that's happened thousands of times in hospitals. Sedentary lifestyle, people that don't get up and move around. Elderly people, chronically ill people, overweight people, truck drivers, anyone that's in a sedentary lifestyle. Okay, this one's a big one for you younger people, birth control pills. Birth controls work by an increase in storing estrogen that makes the body thinks it's pregnant so that the egg doesn't ovulate. This also causes fat storage, which also causes more clots. There have been endless examples here in Siskiyou County of young females that smoke and that are on birth control that have died from pulmonary embolisms or had strokes from clots going into their brain, sometimes as young as 17 or 18. It's tragic. Throw methamphetamine on top of it with smoking and birth controls, you've got a critical dangers. Recent fractures, because your body increases clotting factors to address the fracture or any trauma, and that increases your chance of throwing clots. Again, post-prolonged bed confinement, just like sedentary lifestyle, post-surgery, and also cancer. This cancer is your body's trying, your immune system's trying to heal. It increases the clotting factors of cancer. Anyone that's a cancer patient has an increased risk for pulmonary embolus. They also have a sedentary lifestyle because generally when you have cancer, you're really sick. You're not out running marathons. You have a pretty sedentary lifestyle on top of that. Clotting agents, anyone's on a high vitamin K. And then, of course, age. The older you are, the more likely it is because your circulatory system does not work as well as when you were younger. So any one of those things can cause a pulmonary embolus. If you've got 2, your risks are high. If you've got 3 or 4, it's potentially life-threatening. Any questions? Yes.
What about like blood pooling issues? Like that also increase risk or not?
What's that?
Blood pooling issues.
Like what kind of pulling issues?
Some people have like blood pooling their legs.
Yeah, absolutely. There are more risks. Also, people that have high factor 5 in their DNA, especially Italians, have a much higher chance of having that happen in their DNA. I believe also Asians have higher factor 5, factor 7 in their DNA. But definitely around here in South County, the Italian community, there's a lot of people with high factor 5 that are also at a huge risk factor. Any questions? All right. Well, that was enlightening. All right, CO poisoning. We see a lot of that here too. As a matter of fact, we just had a recent tragedy in the last couple of weeks. That was really bad. Carbon monoxide is a result of combustion. It's colorless, odorless, and is a silent killer. It bonds with 200 times greater to your bloodstream than oxygen does. So for every oxygen atom your alveoli take into your bloodstream, it'll take in 200 of these first. So if you're breathing it, that's what you're going to be putting into your bloodstream instead of oxygen. Signs and symptoms: it makes you turn really red, headache, sleepy, grogginess, lost coordination, general ill feeling. May appear to be drunk. We had an incident July 3rd, not this last July 3rd, July 3rd, about 12 years ago. Mass Shasta PD got called to a drunk subject in the Rite Aid parking lot. Went and talked to the guy. Guy was obviously drunk. They did a PEZ on him, which came back to 0. PEZ is an alcohol sniffer. Came back to 0. Didn't smell any alcohol in the guy either. Said something was right. Fortunately, the officer was a really, really good EMT. Been a firefighter before he was a cop. Was an excellent EMT. Still is an excellent EMT. And started asking questions. Where are you from? Where you at? They said they'd just driven in the night before, and it was I think it was 103 degrees. And said that they were trying to sleep in the daytime after driving all night in a motorhome and had the air conditioner running. And he was trying to get help because he had a severe headache. Then he noticed his where's the rest of your family? So they're still in the motorhome. Went in and found everybody unresponsive, wife and 3 kids. And with 5 carbon monoxide waves, drug all 4 of them out before an ambulance and fire even got there. But ended up, they were running their motorhome in the parking lot and had an exhaust leak that was leaking into the cabin of the motorhome. And if you hadn't gotten out, tried to find some aspirin or Rite Aid and been acting drunk, they'd have probably all died. Any questions? We get an average of 4 to 10 fatals a year just in South County from carbon monoxide every single year from improper heating and ventilation. Any questions? These are just happy subjects. Yes.
For recovery from carbon monoxide poisoning.
They put you in high flow too, and they just run it out of your system. That's all they can do. There's a number they'll take it on arterial blood gas. I know there's a number that's a point of no return, but I don't know what else off the top of my head. But yeah, they'll put you on CPAP or on high flow oxygen and hope for the best. And hope that you can process enough the oxygen that you didn't get too much carbon monoxide in your blood. Any questions? MRSA. You guys need to know about MRSA. So there's a lot of disinformation in the healthcare industry and EMS about MRSA. So the first thing you need to know is that probably within 3 weeks of running on a fire department, an ambulance, or being in an ER, maybe even probably 12 hours after your observation time in the ER on the ambulance, you'll be MRSA positive. Physically impossible not to be. The good news is that your immune system, unless you're extremely immunocompromised, is going to learn what it is and it's going to kill it. It's a flesh-eating bacterial infection. What it is. It's everywhere. MRSA's everywhere. This is why you guys need to know about it. So people go, oh yeah, we're all MRSA positive, no big deal. We're all carriers. We are. But here's why it's a big deal. So if you have someone that has an active case of MRSA, so for you, if you get exposed to active MRSA, you'll kill it. Not a problem. It's probably not going to affect you unless you're in a severely immunocompromised position. So yeah, it's not gonna affect you. It's not gonna bother you. What does Brian always say? It's not about you. It's about your patients. So MRSA is active MRSA is extremely contagious. So you pick someone with active MRSA, it's no big deal for you. You're going to take them to the hospital, you let the hospital know because they should be taking proper precautions. And you don't completely sanitize your entire rig and everything that patient touched. And then you go pick up your next patient that's an elderly immunocompromised person with pneumonia or respiratory infection. Their immune system's not going to be able to kill the MRSA. And then the MRSA will kill them for 24 hours. So it's a big deal. So a positive MRSA patient is a huge deal. You have to disinfect everything from your clothes. You need to gown up and then disgown afterwards. Anything that comes in contact with that patient has to be completely disinfected before you go to the next call. And yes, you will see nurses, paramedics, and EMT go, no big deal. I've already beat MRSA. It's not about you. It's about your patients. Yes, you will see low quality people that will say that to you. I hope by you taking this class, you're educated enough not to kill your patient because it's no big deal for you. Any questions? All right. TB. Everybody got their TB test, right? It also runs like wildfire. And yet you can carry it. Someone coughs in your face, you're going to be carrying it. It will spread rapidly. It's bacterial infection. If you do not get it treated promptly, it could be fatal. It's highly contagious. It runs through schools and nursing homes like nothing you've ever seen. And communities that are high density communities, you get one TB patient, it becomes a pandemic real fast. Any questions? It's not all bad. If it wasn't for tuberculosis, we wouldn't have Disneyland. It's the only reason why we have Disneyland. Any questions? True story. It's a true story. Tuberculosis is the reason why we have Disneyland. Because the only reason why Walt Disney went to Hollywood was because his brother Roy was there, because his brother Roy, who was actually the financial genius that made Disney happen, had tuberculosis. He was one of the first survivors. They moved him to an infirmary in Anaheim. That's why Walt followed his brother there. Huh? Yeah. It only exists because of TB. If TB didn't happen, it would have never happened. Question? Or are you just moving your hand?
Can you have TB and no symptoms?
Yes. You can be carrying TB. So your immune system can get TB. Your body can get TB and you can kill it. But you can still be carrying active TB on your body and still spread it to another person. That's where the problem with TB is. That's how contagious it is. And the weaker immune system people that are already sick, already have a cold or something else is going on with them, again, it will spread like wildfire. Yeah, if you're a young, healthy adult with good immune system, you might get TB and you'll probably beat it. But once it takes hold and gets really bad, you're not going to beat it. And the people that are immunocompromised won't beat it. Or if you literally do nothing and don't treat it at all, it'll eventually get you. Any questions? That's why hospitals won't let you near the door without a negative TB test or proof that you don't have it. Because it can wipe out an entire hospital patient staff literally in days. Pneumonia, also known as pneumonia. This is the end result of most of the diseases we talked about. Most of the viral upper respiratory infections and lower respiratory infections, those viruses themselves don't actually kill you, but they lead to pneumonia, which then leads to sepsis, which then leads to septic shock, which then leads to death. Signs and symptoms. This will be on the test. Generally begins with flu or cold-like symptoms. Might only hear rales on one side because that's where all the pus and the infection is on one lung. It's in both lungs. It's called double pneumonia. It's 2 lungs. They'll have signs and symptoms of septic shock, warm, flushed, wet skin, severe weakness, low blood pressure, hacking up yellow and green sputum. It's lovely stuff. Any questions? A lot of these people wait to the last minute to call you. They're already in full-blown sepsis and impending respiratory failure. It's not uncommon. Any questions? Oh, here's something I hope you'll really like.
There are abnormal breath sounds that you should be familiar with. Snoring, caused by partial obstruction of the upper airway, often caused by the tongue. Stridor, a harsh, high-pitched sound heard on inspiration, is common during upper airway obstructions. Croup is an example of an upper airway obstruction commonly found in young children and is usually associated with a seal-like barking cough. Wheezing is generally a whistling sound due to the narrowing of the patient's airways from edema, bronchoconstriction, or foreign body aspiration. Rhonchi is a rattling sound heard in the larger airways caused by excessive mucus. Rales are a bubbling sound heard in the smaller airways, typically when they fill with fluid, commonly encountered with CHF and pulmonary edema.
Now you know what rales sound like. That's fluid backing up in the lungs. This is what stridor sounds like.
Hello, it's Wes, Super Wes here. In this video, I'm going to discuss stridor. Stridor is caused by doubling or obstruction of the upper airway. Stridor is wheezing, but it's usually heard during inspiratory phase, whereas in this diagram, this is the inspiratory phase and this is the expiratory phase. These are the lines that denote wheezes. So during inspiration, stridor can be heard without a stethoscope. It originates from around the pharynx and the larynx. So therefore, it can be heard during inspiration without a stethoscope. You can hear it standing next to them. And sometimes you can hear it on the exhalation too. The causes for this are croup, that's very common with pediatric patients, along with the barking when they cough. It could be a foreign body in your airway. If they have a nickel in there and stirring a little bit sideways, that'll cause stridor. It could be a tumor growing in their airway. It could be some sort of inflammation in the upper airway. One example is epiglottitis. There is viral and bacterial epiglottitis. Now it's very, very dangerous. If you are not sure what the cause of this is, do not inspect the airway. Don't do the tongue depressor. Don't touch anything in your oropharyngeal airway, just so you won't cause any further inflammation or occlusion. Common treatment for stridor and different causes are inhaled corticosteroids, systemic corticosteroids, inhaled racemic epinephrine, or adrenaline. In any situation, stridor is a sign of a serious medical condition and should be seen by a doctor in the emergency room as soon as possible. Okay, thank you so much for watching. Bye.
All right, any questions on Strider? Ronchi is more upper than lower, but it sounds pretty much the same. That's why a lot of times I'll call them crackles.
So, in this video, I'm talking about the breath sounds are often referred to as rails, bronchi, and crackles. Which is which and what do you use for more practical purposes? When you're actually working and charting and getting the board or making a call, this more accurately describes what you should be doing. Rails and bronchi are outdated terms, and nobody will know what they mean. The term you should use is crackles. But there's three different things you should include with the term crackles. First, the type of crackle, like fine crackles, the medium crackles, or the coarse crackle. And when you hear them, you hear them during inspiration, you hear them during expiration. And what part of inspiration and expiration you hear them? And where are they in the lungs? Right over the lobe, or maybe whole left side, by the color. And that will give you a good description of the breath sounds. Crackles happen when there is air passing through and around fluid and mucus in the lungs, main stem, bronchus, or upper airway. An exception to that is atelectatic crackles and fourth cause atelectasis. Atelectatic crackles are fine crackles in the ends, inspiratory veins, and they're usually in the lower lobes. My diagram here shows inspiration and expiration. Fine crackles sound like Velcro would be thought. They can be that kind of crackles. They can be the beginning of creating or the pulmonary demon. Medium crackles. They're usually scattered about and the fluid getting more built up or the swim from them. Coarse crackles. Usually when there's a lot of fluid present, you know about crackles. If you hear crackles and you listen to somebody's chest, it is in their upper airway, their nose, or the back of the throat, it will echo all through their lungs. So ask them to clear the throat. And also the limbs on their chest. Ask them to go. If it resolves itself. You don't want to disregard it because they're able to follow it up. But you want to be able to charge it, they're able to clear it out. For example, what the film look like. Also, if your patient has an endotracheal tube or a trach tube, crackles are not normal breath sounds. They should have clear breath sounds just like everybody else. It just means that they need to be cleared out. They need to cough it up, and if we get suction, we do it too. So just to summarize, the crackles are either fine, medium, or coarse. Chart when they happen in inhalation or exhalation, and where they're at in the lung. Okay, thank you so much. Bye.
Questions? Questions? Scared the hell out of me. Dude. It's a good one. Any questions? Won't be on the test. So, MDIs are meter dose inhalers. Again, there's a lot of misinformation out there on using them. So there's rescue inhalers and there's maintenance inhalers. And unfortunately, a lot of the maintenance inhalers get confused by the public due to lack of education as rescue inhalers. So maintenance inhalers are generally steroidal inhaled steroids. Like Advair, what's that?
Semaphore,
Yeah, it's another one. Drawing a blank on the others. Advair is the most common one now, it's usually in discus. That's not gonna help you if you're having any type of respiratory distress. All that is an inhaled steroid you take every 24 hours to try to keep inflammation out of front of that. If you're already having one, taking that's not gonna help, but unfortunately, people just don't seem to understand that. Albuterol is the number one rescue inhaler in epinephrine. And then albuterol, probably 80% of the people don't take correctly, because they put it directly in the mouth and don't use the space, or they lose about 70% of it. So make sure you do your 5 R's before you assist someone with it. Make sure you get basal contact before you assist someone with it. Any questions on meter dose inhalers? I can tell you, when I started in EMS, we used to get about 6 to 10 respiratory distress calls a week for people with COPD or asthma. Used to just be a regular thing you just get. Now we're lucky to see 2 or 3 of these a month. Because of steroidal inhalers and home nebulizer machines. Whereas if we give the nebulizer for EMS, most people can just do that at home now. So it's dropped to 911, so we don't see it nearly as much as we used to. Same with CHF. We used to see CHF all the time. They've got some really good preventative meds out there that if people take them, keeps them out of major CHF events. Any questions? It's okay though, those 911s have been replaced with overdose and seizures and all kinds of things. Any questions? So if a patient's not able to use their meter dose inhaler, it's time to start bagging them. And of course, if the 5 R's aren't there, you don't do it. Any questions? Make sure you have base hospital contact, follow your 5 R's. Any questions? Oh, look at that. Bottom left-hand corner. That's how to do it correctly. Any questions? That's the wrong way to do it. Any questions? All right, let's go over CPAP again. I know we already went over the, let's do it again because we actually have the time to do it. CPAP stands for continuous positive airway pressure. Basically puts you into a higher atmosphere so your lungs stay inflated and you get the most gas exchange from your alveoli. Remember, Americans are pretty lazy people. Back in the olden days, 100 years ago, you had to go 4 to 5 miles just to get water in a day. Now we just turn a faucet on and get it. We don't have to do that anymore. We watch a lot of TV. We drive everywhere. No running, no hiking, no talk. No, most of us just don't do that. So we're usually only, our lung capacity, I believe, is what, 1,200, 1,500 millimeters, cc's. And we generally only use about 400 of that to 500 of it. And the rest of it kind of sticks together, the alveoli. That's called atelectasis. And what CPAP does is it dilates those and reopens them, and we get to use the oxygen that we should be using to begin with. If you're a Native American messenger and ran 18 miles a day, you get full use of all your alveolars. If you eat pizza and drink beer and watch sports all day, you're probably only using about 40%, not even 40% of it. Any questions? All right, indications, they gotta be older than 8 years old, because they gotta be able to handle the pulmonary pressures. Severe distress, it's CHF with pulmonary edema, it is the perfect tool. People that are near drowning that are not altered, that can still respiratory drive, those are your indications. Your contraindications, under 8 years old, impending respiratory failure or respiratory failure. Of course, cardiac arrest, agonal respirations, that means like a breath every 15 seconds. That's end-stage respiratory failure, is agonal respirations. Severe decreased level of consciousness. Anyone with the blood pressure below 90 systolic, because it's gonna drop their blood pressure even more. Anyone with a possible pneumothorax, is gonna make it a lot worse. Anyone that can't maintain their own airway. Or anyone with major trauma or chest trauma. Any questions? Those are contraindications. To use the CPAP. What can go wrong? Well, hypotension, because it's gonna happen. And of course, a pneumothorax, they've got a tiny hole, it's gonna make it a big one. No one cares about corneal draining. It's the truly emergency center. Or emergency incident. No one cares if the eyes get right out. Any questions? You really want to watch that? You don't want to watch that. It's boring as hell. Respiratory failure. So if someone's been respiratory stress too long, they're going to run out of energy. You can only do that for a certain period of time, no matter how strong you are. So how do you know when there's going to be respiratory failures? Because there will be test questions on it. The respirations will slow. Your SpO2 will drop. Their level of consciousness drops. They lose muscle tone. They start becoming bradycardic. Those are all the signs and symptoms of respiratory. So let's say you get there, you get someone oxygen, severe respiratory distress, and the respiration slow. You go, yeah, it's a good thing. It's only a good thing if their pulse oximetry comes up. If the respiratory slows and their pulse oximetry goes down, and their level of consciousness goes down, that means you need to start ventilating with a bag valve mask in the system. Does that make sense? Just because, same thing like I always say, never base your assessment impression off of one sign or one symptom or a number. If the respirations are going down, it can be a good thing or it can be a bad thing. That's why you got to look at all your signs and symptoms. Any questions? Any questions? All right, case study. You're dispatched to an unknown medical. Scene size up. Is the scene safe? Nature of illness. How many patients are there? Do you need help or resources? Are there any spinal complications? Any questions? All right, scene size up. You and all your team have your BSI on. You're confirmed the scene is safe. You see a woman sitting on the floor of her home struggling to breathe. She is the only patient. What do we do next? Primary assessment. Patient's in her early 20s, severe dyspnea. She is alert and only able to speak one-word sentences. It appears to be a life-threatening emergency. The radial pulse is present. Her breathing is at a rate of 32 breaths per minute. And she's turning blue. Is that adequate? So what do we do? BVM. So we get a BVMer. Is she a rapid transport? Do we wait for advanced life support or we start transporting and request it en route? Start transport, never delay. Boom. What's next? Oh, it's history taking. Don't listen to that. It's sample. She can't give you any information. So then we go to, oh, maybe she can. Sorry, this is messed up. Patient has boyfriends on scene to answer question. Began having shortness of breath during an argument. She's allergic to some antibiotics and shellfish. Medications, albuterol. History of asthma. She had a grilled cheese sandwich about 25 minutes ago. Vince Linton, they had a fight just after dinner. He had cooked shrimp for himself and a grilled cheese sandwich for her. She became short of breath during the argument and began to turn blue. What's next? OPQRST. Any questions? All right, vitals obtained. She's turning blue around the lips and nose. Accessory muscle usage, bilateral wheezing, poor tidal volume. And her blood pressure started to tank and she's tachycardic. What's wrong? Yeah, severe allergic reaction. She's allergic to amoxicillin and shellfish. What happened? He cooked shellfish and then cooked her grilled cheese sandwich in the same pan. And she turns completely red. Blood pressure is now non-existent. What are you guys going to do besides ventilating her? Epinephrine. All right. Any questions?
Will we start doing, KRSD night and?
Yes. Well, no, you're still gonna be doing trauma today.
Okay.
We'll start medical assessments a week from the night. All right, go to break. Be ready to go at 8 o'clock.